So hello and welcome to my YouTube channel. My name is Ongoi Mangi and I'm a Kenyan RN. I do videos on nurse education, patient teaching as well as health education, and today I come back with the topic on the midwifery episode 3, and this will be about the physiological changes in pregnancy or the normal changes within the pregnancy. So if it's your first time here, please take your time to subscribe and hit the bell icon so that you're notified every time I upload informative videos such as this one. And if you're a returning subscriber, know that I deeply appreciate you. So let's dive right in. It is important to note that body changes are normal in pregnancy, and this change is multifactorial but mostly mediated by hormonal changes. All body systems are changed to adopt the pregnancy, and these hormonal changes mediate a physiological adaptation to the pregnancy, preparing the mom for the pregnancy and childbirth. It also prepares the mother to nurture that child after it is born. So we're going to look at each system on its own, but entirely almost all the systems in the body will be affected by pregnancy because of the hormonal changes. And in the respiratory system, you will see the respiratory rate changing per minute per volume, and there will be increase of carbon dioxide blown off to facilitate oxygen because more oxygen will be required again to transfer to the fetus. The tidal volume also increases by at least 200 mils by the end of pregnancy. When we go to the endocrine system, the pituitary hormones, that is, there will be lower FSH and LH, that is follicle stimulating hormones and luteinizing hormone, and this is due to increase in hormone progesterone and estrogen. This is because ovulation will not be needed during pregnancy, but there will be a raise with prolactin and oxytocin. So these are different hormones that will be very essential. We are going to look into each system on its own in details. Again, in the cardiovascular system, almost everything will change. There will be an increased cardiac output, the blood volume will raise, there will be an increased stroke volume. There will be a difference in the pulse, and it will be on the higher side, it will be rising between 10 beats to up to 20 beats. So if normally this person has an average pulse rate or heart rate of, let's say, 70, it could go even at as high as 90 or over because of the pregnancy by the time we get to term. Then the peripheral vasodilation is also expected and a raised cardiac output. Then we are going to see further changes in the cardiovascular section or in the system once we get to that part. Then in the urinary tract, the GFR will increase due to an increase in the plasma volume. And this means that if we have more water in the body, then there will be an increase. They need to increase the GFR so that the body or the kidneys are adapting to the new volume. Then there will be more smooth muscle relaxation of the ureters, raising the risk for UTIs and pyelonephritis. So it is important to observe the woman holistically to ensure that this will not happen. In the hormonal sides again, we have hormones progesterone and estrogen raising, and human placental lactogen. And this human placental lactogen is the hormone that actually works on the breasts, enlarging them and preparing them for lactation. Then we have the hematological changes, and this include the raised plasma volume we had talked about, and this could go higher even by 50%. And then there is reduction in the platelets. There will be an increase in the white cell count because it's a soldiers of the body to improve immunity. There will be a raise in the fibrinogen and factor 8. This will mean that the person can go into hypercoagulable states. And there's something else called hematological or physiological anemia. Due to raised plasma volume, the red cells in the blood may lower slightly than normal, not because the woman is anemic, but because of the dilution. So in the cardiovascular system, there will be an increase in the heart rate by 10 up to 20 beats per minute, and this is expected because there is an increase in the cardiac workload or in the workload of the heart. The heart will also increase slightly in size due to the increase in the workload, and the cardiac output increases significantly because before pregnancy it is up to 2.5 liters per minute before the pregnancy. After pregnancy, within the first trimester, this will double to 5 liters per minute, and then by the time we get to the second trimester, this will increase to 6 liters, and at term will be at 7 liters per minute at term. So there is a significant raise in the cardiac output. Then there is also an increase in the stroke volume, and this is the volume that is pumped out of the heart with each single heartbeat. So with each beat, there is the increase in that volume. Again, we are talking about the increase in volume because there will be increasing of almost everything to make room for the developing baby and to ensure mother and baby are both healthy and adapting. The blood volume will also increase, and this is by up to 30 to 50% from the initial stages of pregnancy all the way to term. Then there's the physiological anemia I talked about because of the raised plasma or the increase in plasma, and this is because of the dilution and not specifically because of the cells being fewer than they are. Then the blood pressure will change differently within the trimesters. In the first trimester, the blood pressure will reduce slightly than normal. Then in the second trimester, will start rising again, and by the time we get to the third trimester, then it will have risen to the normal rate or slightly higher. However, it is very, very important to monitor the blood pressure in a pregnant woman because in the event that they have a raised blood pressure or hypertension, again, that needs to be picked, especially if it's just happening because of the gestation. So the hematological changes in pregnancy are quite a number, and this begins with the plasma volume increment, and this is what I talked about, and this could go higher by up to 50% of the normal plasma volume. This causes a delayed increase in the RBC mass and the volume but less plasma, but less than the plasma volume. Normal pregnancy associated with a demand of 1,000 milligrams of additional iron, and that is why we do supplementation of iron, or we get the IFAS, and this IFAS is to help with the blood building ability so that we raise the number of red blood cells and other cells of the blood, but more specifically the red blood cells because we don't want the person to be anemic. Then there is about 60 milligrams of elemental iron that is required daily, provided in 300 milligrams of ferrous sulfate. And you would know that this is the amount that is actually in the IFAS that is provided in the government facilities. This is usually due to the increase in demand, and again to ensure that mother and baby are adapting well. So then we look at the respiratory system changes, and we do have the anatomical versus the physiological. In the anatomical, there will be increase in chest diameter, submucosal angle will change, the subcostal angle will change, increasing the diaphragmatic excursion, with the diaphragm will be raised up to 5 centimeters above the normal level to make room for the bloating or increasing abdominal girth or the bigger uterus that will be. Then the physiological one, there could be hyperventilation, there would be increased tidal volume, minute volume, and residual volume. Residual volume will be decreased while expiratory reserve volume will decrease. Tidal volume will increase by up to 40%. And the partial pressure of oxygen again will increase while the partial pressure of carbon dioxide will decrease. This again is to make sure that both the mother and the child are getting enough oxygenation and that their saturations are within normal ranges. Arterial pH will remain unchanged and serum bicarbonate will reduce. So when it comes to ventilation and respiratory gases, there will be an increase of demand of the oxygen consumed or consumed, and this will raise, or the demand will raise gradually during pregnancy, and will have increased by up to 20% at term. During labor, again, this will be needed. A lot more oxygen will be needed, especially for the mom, so that they're able to have the powers to push out the passenger, who is the baby. When it comes to the reproductive system, the uterus, the cervix, ovaries, vagina, and breast will all be affected. And before pregnancy, the uterus is a small pear-shaped thick-walled muscular organ weighing about 60 grams. At the end of pregnancy, it is a large, thin-walled organ weighing about 1,000 grams. And the capacity is usually raised from 10 mils, usually, to about 5 liters. So you can imagine something that is 5 mils is really, really little, and it expands to absorb at least a 5-liter gallon of, that is a big, big volume. Then the cervix, usually it will secrete thick, sticky mucus to form a mucus plug that will block the entrance of the cervix, and this will actually keep the baby safe and will prevent microorganisms from entering through to the vagina into the side where the baby is. And during labor, the cervix will start dilating and the mucus plug will be expelled. So the initial stages of labor, the first sign is the bloody show. It's called bloody show because it will be mucoid and it will have some blood in it. But then once that is there, it is one of the signs that this person is progressing into labor. Then we have the Godel's sign, and this is a softening of the cervix, and it is usually noted at 8 weeks. And we have the Chadwick signs, which is a purplish blue color of the cervix and the vagina, and again at 8 weeks. Then we have the ovaries, and ovulation will not occur during pregnancy, as I talked about it earlier. And this is because of the suppression of the pituitary hormones, FSH and LH. FSH is follicle stimulating hormone, and LH is luteinizing hormone. They will not be required because we are not requiring to have ovulation, because already ovulation happened and fertilization happened, and now we are trying to nurture a living being in this woman. So the body itself will adapt and this will not occur. So definitely there will be no menses like usual. So the monthly periods will cease. There will be no ovulation, and corpus luteum produces estrogen and progesterone until week 8. This is because when the baby is forming, before we get to the embryonic stage, we have a zygote. When fertilization occurs, it's just a bunch of cells, then they start dividing rapidly to form a morula, and then this morula will continue subdividing and grow into the embryo, and then these embryonic cells will continue dividing to form the distinct parts of this child or fetus. So at week 8, we expect that now the placenta has formed and will start producing hormones for the baby in conjunction with the ovaries. So this corpus luteum will continue producing that a lot of hormones, or a good amount of the hormones, to sustain the pregnancy until we have a functional placenta in place. Then in the vagina, estrogen causes loosening of the connective tissue and increases in vaginal secretions. Some of these could be good for sex and other times it could not be. So it depends on someone. Then we have acidic secretions will be secreted to ensure that we do not get bacterial infections. But sometimes this is not as effective as it should be, and this causes a lot of bacterial infections during pregnancy. However, the body has a way of regulating it by making the vagina more acidic and producing even more acid. Then we have increased glycogen in cells that may enhance the growth of Trichomonas vaginalis or Candida albicans. So these two are a menace, and therefore the patient should be observed closely during the clinic attendance, during the 4 visits. It's good to rule out any of these infections and treat them. When it comes to the breast, there will be breast enlargement, of course, and the nipples become more distinct and erect. Areolas will darken more, and the Montgomery tubercles will enlarge. Those small dark spots on the areola. Then we have colostrum, and this is antibody-rich yellow fluid secreted in the last trimester for the first 2 to 3 days after birth, gradually changes to milk. It is okay if you have this colostrum leaking a few days or a few weeks before your child is born. It can happen. It happened with my firstborn. It didn't happen with my second. I just had a lot of it, and I had so much milk that my child could not get through all of it. So I had to keep pumping once they were born because it was just too much. And the pain of engorgement, you do not want to experience it. If the baby is not feeding as much as you're producing, then you can actually pump it and preserve it, because you will need it by the time you get back to work, because baby will need milk. So in the renal system, there are anatomic changes, and this is where we have the kidneys increasing in size and can reach up to 2 centimeters in length, more than usual. And then there is also an increase in the vascular volume, because remember we had talked about the hematological changes and the blood volume will increase. Then there will be increased interstitial space and increased glomerular size, not in number but size. And this is because of the increased workload again. The greatest changes are seen in the collecting system, and where the calyces, renal, pelvises, and ureters dilate and elongate. These changes are evident by the 3rd gestational month and can persist until the 12th week postpartum. Again, another thing that will happen in the urinary system is increased micturition, especially towards the end, in the 2nd and 3rd trimesters, where the baby increases in weight because of the pressure symptoms, as the baby will be lying on the bladder at times. So then we have the hormonal changes or the endocrine changes, and in the parathyroid gland, this gland increases in size slightly, and it means the increased requirements for calcium needed for fetal growth. Because remember, we said we have about 256 bones in the human body at that age, and all of them will be formed from the calcium the mother has in their system, and therefore this parathyroid gland helps with meeting the calcium needed. And remember, if you do not have enough, the baby must be formed, and therefore you will be left with deficits yourself, and sometimes you can actually be put in calcium supplements, especially because the demand for calcium is quite high during pregnancy. Then there is posterior pituitary, and this will begin to secrete oxytocin that was produced in the hypothalamus and stored there. It will serve to initiate labor, so it is more important towards the end of the 3rd trimester. Then we have the anterior pituitary, and this is at birth. The anterior pituitary will begin to secrete prolactin, and this will stimulate production of breast milk. Again, towards the end of the 3rd trimester, beginning of the 4th. Then we have placenta, and placenta produces large amount of estrogen and progesterone by 10 to 12 weeks of pregnancy. Remember, we said from the 1st week to the 8th week, we are going to get these hormones produced by the corpus luteum, after which the placenta now will have been formed and in place and will begin producing these hormones as needed. This serves to maintain the growth of the uterus and to help, and also helps in controlling the uterine activity. Placenta hormones are quite a number. There are different ones, and mostly the most significant one is the estrogen, progesterone, and human placental hormone. These are responsible for breast changes, skin pigmentation, and uterine enlargement in the 1st trimester. Chorionic gonadotrophin or human chorionic gonadotrophin HCG is the basis for immunologic pregnancy test, and this can be tested either with a urine sample or blood tests. And then we have the human placental lactogen. This simulates the growth of the breast, because you see they're going to enlarge. We're going to have more distinct areola, they will darken more, and the increase in size of the multigomarid tubercles that are found again on the areola, and again the nipples will become more erect than normal or noticeable. So then now we have the musculoskeletal changes in pregnancy, and this can be seen in the ligament laxity, and this occurs throughout the pregnancy. and progressively there will be more bothersome back pain, not uncommon in pregnancy. There is the pride of pregnancy. As this increases, there is the pregnancy posture where the back tends to go towards the abdomen and there is a neck, or I cannot remember the term that is used. Then we have total calcium levels will increase, but ionized calcium levels will remain normal. There will be an increase in PTH and relaxin, and there will be no loss of bone density during pregnancy. When it comes to skin changes, there could be those vascular spiders or different blood vessels showing on the skin in a web-like manner. There could be palmar erythema or the palmar surfaces appearing more red. Then there could be striae gravidarum, and these are stretch marks that forms on the abdomen. There could be hyperpigmentation effects, and we have two types. There is the mask of pregnancy, and especially if this is the first pregnancy, this is how our mothers or our foremothers used to know a girl is expecting even before they know that they are pregnant, because the mask of pregnancy appears quite early, and someone with experience will actually tell there is the mask of pregnancy. Then the linea nigra is a line, a vertical line that emerges from the umbilicus down to the pubic area, and this line is darker and noticeable, so those are hyperpigmentation. Very unique but not very noticeable. Then there is increased fine hair growth while pregnant. The hair actually gets very silky. I had my locks on with my two pregnancies, and the increase in length was remarkable. It is quite nice. But again, this happens during pregnancy. You will get very silky hair, longer, healthier, volume will be okay, until now again you deliver and you start breastfeeding and it starts falling out. That's a story for another day though. Then there is pruritus at the end of the pregnancy with cholestasis. In the gastrointestinal system, we have a number of changes, and one, there could be increase or decrease of appetite in the first trimester, but usually it increases, and there is cravings of different things. Different people crave different things at different times. However, you need to be as careful as possible not to overdo on the very unhealthy things. Then there is gastric reflux because of the gastric sphincter relaxation. GI motility or gastrointestinal motility reduces, and this could lead to constipation. The gastric reflux would actually lead to heartburn. Then we have gastric intestinal transit time slower, and therefore it means somebody should get smaller meals so that they are able to navigate through the system, and by the time they are getting the next meal, they still have space for them. Then the liver functionally is unchanged, while the gallbladder will be a little bit dilated. So all metabolic functions are increased during pregnancy to provide for the demands of the fetus, placenta, and uterus, as well as for the gravidas, increased basal metabolic rate and oxygen consumption. Protein metabolism is enhanced to supply substrate for maternal and fetal growth, and fat metabolism increases as evidenced by elevation in all lipid fractions in the blood. So these were the references that were used. There is a lot more changes that I did not include here, but this is quite comprehensive on the changes in pregnancy. There is changes in very many areas in the body, but the significant ones have been mentioned in this video. Thank you for watching through the video, and the next video in this episode will be about the warning signs or those changes that you'll experience in pregnancy and know it is time to see your gynecologist or obstetrician as soon as possible, or to call an ambulance to get you to the nearest emergency room.